Welcome to The Inside Track, where we talk all things health, healthcare and medical insurance. Brought to you by TRA and our team of Warren, Alan and Doc Avron. Let's sit back and see what our team has for us today.
Hi everyone, and welcome to our next edition of The Inside Track. I must tell you, it's amazing the response we've had to our medicinal cannabis podcasts. Between the two of them, part 1 and 2, we're probably sitting on just over 3,000 views, which is fantastic.
Absolutely.
And I guess we knew this would have that sort of reaction, but a lot of people are interested in it and the benefits that we highlighted.
Yeah.
I think it's also nice to see that we are slightly more relaxed today compared to our last one.
Those of you, exactly.
No ties. Those of you who saw our podcast last time.
No makeup.
No makeup, none of that.
Moving into the summer season.
Yeah, there you go. So,
and Warren, just to go on that, I mean, we are covering such relevant medical topics.
Yep.
From my side, Alan's covering such interesting topics from the payment and fund side, and
Yep.
I just think it's all relevant. So,
Yeah.
so it's great.
and the interaction we've had and the comments we've had from people is that we are staying relevant, and we're asking those questions that need to be answered. So that's great from our side. But for today, everyone, you've had a chance to speak to a doctor regarding the management of pain. Let us have
Exactly.
a bit about that.
It's a very significant problem out there. As we know, people have a lot of pain, particularly back pain and lower back pain. I mean, anyone who's sitting down in an office working on a laptop, just those hours and hours, and it's such a relevant topic. Should people do surgery? Shouldn't they do surgery? How do they treat the pain? And we've had a lot of questions about it. So I thought we'd go to a specialist, and Dr. Corey Avenant is a specialist anaesthetist with a special interest in chronic pain management, particularly back and lower back pain management. And he focused on the non-surgical treatment of chronic back pain. And he had some very interesting comments on that. So I had the chance to interview him, and let's see what he has to say.
Sure.
So welcome, Corey. It's so nice to have you.
Thank you, everyone. Thanks for the opportunity. Thanks for the invite. I appreciate.
And we really look forward to unpacking this topic of chronic pain and chronic lower back pain, because I think it's very prevalent, and maybe we can start there. In fact, how prevalent is chronic pain and then chronic lower back pain in the population?
Yeah, there was a study, actually a South African study done by Prof. Meyer in Pretoria University, and they did a study already in the 90s. And on that study, they find that up to 65% of all patients will experience somewhere in their life back pain.
What actually is chronic back pain? And how do you differentiate acute chronic back pain, that's a short period, to actually chronic back pain?
That's very good question. So chronic pain is all pain more than 120 days continuously. That's chronic pain. Less than that, we talk about acute pain. Then what's very interesting, if you look at the low back pain, to say that the patient has low back pain mean not much. You as a clinician must be able to can identify what is the structure in the back that caused the pain. And if you look at the studies of Dick Bochtok and Manchakanti, they've identified 4 structures in the back that can cause pain. That's your facet joints. And interesting, 60 to 65% of all patients will have actually facet joint pain. Around about 30% will have discogenic pain. That's the second structure that causes pain. Then the radicular pains. That's around about 5% of patients will experience that. Another 5 to 10% will experience SI pain, sacroiliac pain. So that's the challenge of the doctor before he treats low back pain to make a proper diagnosis of what structure caused the pain. We do from SAPSIS, that's a South African Pain and Spinal Interventional Society. We go out, that's our main aim, is to go and train and teach our doctors about low back pain and make the correct diagnosis. And we have a congress coming up on the 25th and 26th of October. And what's beautiful about SAPSIS is that we invite everyone, specialists, GPs, physiotherapists, chiropractitioners, biokineticists, everyone with an interest in chronic low back pain or in pain, chronic pain, we invite to the Congress.
That's really interesting. And there's obviously a lot of education that needs to happen around it. But just to unpack, I mean, you're a specialist anaesthetist. Tell us a bit about your role and your journey to get into the management of chronic back pain.
Yeah, I was a resident at Wits University. And part of our rotation is that we went through Hillbrow Hospital. And at that time, I'm talking about the early mid-90s, Prof. Shipton was still the head of anesthesiology at Hillbrow Hospital, and he had the pain clinic, and we were rotating through that. So that was where the intersects have started. And then when I got into private practice, I saw that many things was not been done correctly. And I've realized the only way for me forward is if I go and get this information, the knowledge. And from there onwards was a beautiful journey that I've started of going to the first pain congress in 2002, and from there it have snowballed, and now my big role is to spread that knowledge to all service providers, all doctors that have an interest in chronic pain. Interesting, everyone. I was now recently down in Cape Town seeing one of my old profs, and he was saying, Corey, the big problem that we have is that the GPs can't make the diagnosis and treat low back pain. Train them. And that's exactly what we're doing.
Mm. So from where you started, where it sounds to me there was a sort of lack of knowledge, where would you say we're sitting in 2025 in terms of the average GP out there understanding the causes of lower back pain and how to treat it?
I can't talk about the average GP because I don't have that knowledge. I can just say to you, to sepsis, there's at this moment 218 GPs belong to sepsis. And those GPs know how to treat low back pain. I'm very proud about that, proud about them. And they give their patients absolutely the best care available. Those 218 GPs with their physiotherapists.
So it sounds that that body of knowledge is increasing, and sounds that obviously doctors are getting educated in the field, which I think is important.
Absolutely.
So let's now dive right into it in terms of we've spoken about the different types of pain that one can experience and how to classify it. How would you approach an individual who comes to you and says, Dr. Avenant or Corey, I've got significantly lower back pain and I've had this on a chronic basis?
Yes. What's important to me is when a patient sees me, I'm the secondary phase of the treatment. The primary phase must be done already. What's the primary phase? That's where the patient sees the GP give the correct medication, refer the patient to the physical exercises, and we train the physiotherapists that they do the correct exercises for these patients. After the X period and the pain haven't improved with 60%, then the patient see me. What we will do first is to make a diagnosis of what is the structure that caused the pain and work then a treatment plan out for the patient.
And what would the treatment options be then? Because what you're proposing here is potential, and we'll get onto it in terms of an option that's not surgical.
Absolutely, it's all non-surgical. We've just done a pilot project for one of the big medical aids here in South Africa. And 300 patients was been seen by us first on primary level with the GPs and the physiotherapists, and then secondary level, the pain physicians, the interventional pain physicians, doctors. And of that 300, we could treat 90% of them at a primary level. Only 10% of those patients went on to secondary level. And not one patient, and that was over an 18-month period, needed surgery.
Wow.
So the saving for the medical aid was enormous.
Wow, that's how many patients was that?
300.
300 patients. That's very significant. Mostly treated at the primary level, and then about 10% going to the secondary level, which would be your group of specialist anesthetists who could treat it without surgical intervention. And I think that's significant because what percentage of surgical intervention do we see in the market? Do you have any idea on that?
Yeah, I know the figures. This is frightening. The incidence of spinal surgery in our country in a patient that have insurance, 35%. 35% of all the patients who have a medical insurance will get a back operation in their lifetime. 25% of the total population will have 2 or more back operations. Now, what you have to ask me, what's the incidence of spinal surgery in the rest of the
Yes.
world? 5 out of 100,000.
Wow.
Wow.
Okay.
Wow.
So
Can you see
those,
the work that's ahead of us? That's
yes.
a beautiful challenge for us.
And that's why we're here today, obviously, to
Yes.
educate patients. And that's where we get a lot of listeners and viewers on our podcast, and we're very excited about that. And hopefully they'll be taking that information on board, because as we've said, a significant number of them would have lower back pain, and advise them on a pathway that they can go. But let's now go to that patient who comes to you. They've been to their primary care physician. They've tried to treat it in a primary way. It hasn't improved. What are the different modalities you would use as non-surgical intervention to actually treat their lower back pain?
The chronic back pain on secondary level consists out of 4 legs, and you do these 4 legs together. The one leg is the interventional pain procedures. So that's the pain blocks that we do or rhizotomies that we do. That go with the correct pain medication. So you have to make a distinction. Does the patient have nociceptive pain or neuropathic pain? Because the medication will differ. Or is that a mix? The next is to involve the physical exercises, the physiotherapist. And according to your diagnosis, they will work out then a treatment plan. The 4th leg of the treatment, and that not all patients require the 4th leg, is psychotherapy. But in your very severe cases, that's an important point, because we must never forget that chronic pain is a biopsychosocial disease. And if you treat chronic pain, you have to treat the patient globally, holistically, multimodal. You involve everything that's available to you. And everyone, you will see not one have the perfect answer. Everyone contribute a bit. Must to put all those bits together. This is where the magic is lying.
So now those interventional spinal procedures or those injections, how do those work? For example, if a patient comes in and sees you, would they need to go would you do it in local, a general anesthetic? How do you actually treat it?
We take the patients to theater for a pain block or a rhizotomy. Why do we do that? First of all, we're in a sterile environment. Secondly, we can then do it under fluoroscopy. So we can place our needle with 100% accuracy and 100% safety. Thirdly, the patient gets a conscious sedation anesthetic. And it's not a horrible experience to them. So they buy into the experience then.
And your outcomes, I mean, look, we've spoken broadly, but in terms of an outcome, someone coming to an individual coming to you, how often would they need this treatment, and what's your success like?
Yes, Avron, I did a study on my own practice. Was a prospective study in 2016 already. I think it's time to do another one, looking into the factors that influence a positive outcome for the non-surgical approach. And we've identified the factors, and then we've weighted them to see which one of these is the most important in the sense of repeating itself. Now, for outcome, the most important was, does the patient had a previous back surgery or not? If they had previous back surgery, the outcome of the non-surgical approach is much less than the person who don't have. The second one was active patient participation. If a patient don't take part in this program that I've just told you, pharmacology, physiotherapy, psychological therapy, the outcome is bad. The next was the different pathologies. Facet pain is much easier to treat than SI joint pain. Why? The SI joint is nerve supply posterior and anterior. We can treat only the posterior part. We can't treat anterior because we have to go through the bladder then. So the outcome of the SI joint is less than the facet joint. So the structure have a matter. And the last and the least was the age. We always say the old granny of 95 days, let's have pain. No. We have saw of those 4 factors, the least important to determine outcome was age.
So you don't have to live with your pain, and more an elderly patient coming and say, well, I've lived with this my whole life. Do I have to live with this for the rest of my life? And your answer is no, you can get it treated.
Absolutely. And Aaron, the big thing for us, chronic pain, you can't stop. It's part of the memory system, but you can decrease it. And with that, you can improve the quality of that patient's life. And that's what's important to us.
Corey, tell us a bit about the costs for these procedures. Are they significant and are medical aids covering them?
If you compare the cost here to spinal surgery, and that's the pilot project that we did now for the specific medical aid, is it's a fraction of spinal surgery. To treat a patient successfully, non-surgically, costs small money compared to surgery. But here's our problem, is that many of the medical aids, and especially the big medical aids, don't pay for our procedures or don't pay fully for our procedures. And there's something very wrong in that, that you save money, you improve quality of life, but you don't get rewarded for that.
So I suppose an individual would need to investigate with their medical aid and see what they pay. But what you're saying, either way, it is a fraction. And even if the individuals maybe have to pay in a bit, it's well worth it in terms of the huge costs of significant back surgery.
Yeah, but I think the point I would like to make here, everyone, is what some of the medical aids is doing is very unfair. They take the fee that we pay out of patient savings account, not out of the hospital. Although the procedure they pay out of the hospital, but our fee, a big part comes from a savings account. Now, here's the big problem with that. First of all, you depleted the patient's savings account. The second is the general practitioner get no angry with you. He say to you, and I've heard it so many times. They say, I won't send a patient to you because you used part of his savings account. There's no money for me and my family as a general practitioner left for the rest of the year. I'd rather send the patient to a surgeon and let the patient get an operation. So can you see the wrong that we have in the system?
Sure. I think that needs further discussion. Corey, you told me when we saw the show, when we were talking just before we started recording, that you've just come back from a conference overseas. Tell us what some of the new latest insights that are coming and some of the things you learned.
It's the IPSIS Congress, the International Pain and Spinal Interventional Society. Now, the aim of IPSIS is to put science and evidence to the non-surgical approach. So that's exactly what I like. But I want to tell you this one little thing. The previous president of the IPSIS was been invited to the White House in the first Trump term and saying, you who do chronic pain, but you do the multimodal approach with pain procedures, with the physio, with pharmacology, with the psychotherapy, can't you as a society help us to address the opiate problem that we have in America? And I thought that was excellent.
I think it's about taking a holistic approach to dealing with issues. And I think what you're saying in sort of the pain society, the Anesthetist Pain Society, Back Pain Management Society, that you're saying is taking a more holistic approach to treating back pain and not diving into the surgical approach.
Absolutely. And we do it evidence-based, non-surgical, and we involve a multi-model approach.
Corey, just as a last few points, maybe, can you tell our listeners who are out there, and maybe many of our listeners either have mild back pain or don't have any back pain as yet, you as a specialist and seeing this on a daily basis, hundreds of patients, what is your advice to our listeners out there to protect their backs, to try and not get into this position that they need treatment for their back pain? How do they keep their back healthy?
Don't be overweight. Do everyday flexibility exercises and spend time even on muscle strengthening exercises. First weight, then flexibility, then muscle strengthening. If you do that, the chance that you will get one day even an interventional pain procedure is very minimal. The pain that you will have, your GP will be able to treat it with a physiotherapist, as we have proved that 90% of the population can be treated like that.
Amazing. And if there's a final message that you'd want to leave our listeners today, what would that be?
Make sure that you get the correct treatment for your back pain. Remember, and I say that to all my patients, pain, back pain, leg pain, arm pain is not an indication for spinal surgery.
Dr. Corey Avenant, a specialist anaesthetist with a special interest in chronic back pain management. It's been an absolute pleasure. Thanks so much for spending the time and educating us. And we look forward to bringing you back onto our show for future episodes. Thanks very much.
Thank you for the invite, everyone. We really appreciate it. It's very good, kind of you. Thank you.
Thanks, everyone, and goodbye.
Wow. That is, I mean, that's just so interesting because here you have a practitioner who is not jumping to cut.
Exactly.
You know, he's advocating that more conservative treatment, which is great.
Exactly. And I think the point that he actually brought up in that in that discussion is that in South Africa, we have particularly high rates for
Yes.
surgical intervention,
Yes.
way higher than the world average.
Sure.
And people should be looking at non-surgical ways to treat their back
Sure.
pain.
And I just read an article last night about it, that DBC kind of treatment is becoming more and more prominent in South Africa. You're 100% right in terms of non-surgical interventions. Most probably quite topical, and I'm glad that we've covered this.
Yeah, and I
Yeah.
think people should understand all their options, you know,
Yeah.
in terms of how to treat it,
Yeah.
how to
I
treat
also
their
like the
low
way
back
that he
pain.
gave that summary right at the end of the three things that if he was speaking to people, the three things you need to, you need to implement to avoid the back pain or the surgery in future. So I like it's nice and crystal clear.
Yeah.
But that leads us to, what is TRA doing in this space? Because as a gap cover provider, we get faced with shortfalls in that surgical space where the reason for the treatment is, management of pain. So what we've done on our TRA space is we've introduced a targeted pain relief benefit, and that'll be from the 1st of January 2026, which I think is fantastic.
benefit. Really
And the important thing about the way we've implemented is that even if your medical aid has said that you need to cover some of that treatment out of your savings account, we'll still top up.
I think
We'll
that's
still
so
cover that
incredible.
short term.
I think we're leading the industry on
Sure.
that as TRA,
Yeah,
and it's
absolutely.
being very progressive, realizing there's this need,
Yes.
realizing members fall short on that, and saying, you know what, we realize it's an important benefit, and we're prepared to cover it.
Sure.
Yeah, and it's market directed.
Sure.
There's a big
So
need
watch
for it.
watch the space. Those of you who are TRA policy holders, you'll be getting your renewal documentation soon, and you'll see that we've got this benefit kicking in for 2026. So very excited
Amazing,
about that.
super excited about that.
But talking 2026, we've all just come through a lot of launches. Medical aids are launching. TRA we've launched from a gap cover point of view. Our competitors have launched in the gap cover space, and the consumer at the end of the day is going to feel the effects of all these launches. So, Alan, I wonder if you could summarize for us from a layman's point of view. How's it going to affect the consumer, the man in the street, now that we've seen this whole host of increases in benefits and premiums?
Yeah. Thanks, Warren. This is normally what we call high season in medical schemes environment. The regulator year on year comes out with guidelines in terms of what medical schemes should look at in terms of premium increases, but it never really gels with the way
reality,
it pans out.
Yeah.
Because, not only particular to South Africa, but across the world, medical inflation is always higher than headline inflation. And we've known at some years now that that inflation runs sometimes 3 to 4% above headline inflation. And it does impact because medical schemes fund procedures, and procedures are influenced by technology a great deal. So a lot of that influence where schemes will come out with increases. But we've seen over the last month and a half that medical schemes increases vary between 6 and 11%.
Okay.
And we know that open schemes are getting less. There's about 14 of them left. But there's one particular scheme that came out with 19%,
Wow.
almost 20%.
Wow.
And that's an indication that that scheme is perhaps in a bit of trouble. But generally, I believe that the increases in the industry are fair. It's a fair reflection of what's happening in our economic environment.
Sure.
Vis-a-vis the profile of medical scheme members. The more you claim, it's a natural outcome.
Sure.
You're going to pay a higher premium.
Yeah.
So some medical schemes were really good in terms of managing their claims profiles. And some, of course, still suffer from a legacy of COVID, and COVID elective procedures has definitely influenced the entire industry. So if you take the top 5 schemes, pretty much between 7, 8, 9%, some are up to 10%, but none of the schemes, or very few of the schemes, has reduced benefits.
Okay.
And that's a very, very good indication for the consumer.
Sure.
It does, in fact, mean that it's a fair price for fair benefits, not a fair price for less benefit.
Sure.
Okay.
Yeah.
So my assumption is that medical scheme members would definitely be better off in terms of what the industry offer, what our country's private health sector offer in terms of health outcomes vis-a-vis what we pay. And I'm quite positive that generally across the board the increases are fair, except those that are in double digits for certain regions and those that are really in trouble in terms of in terms of their claims ratio. The same applies to closed schemes. Some closed schemes are very, very well managed. We haven't seen all the increases, but the indication is that not many schemes will exceed the 9% or going into a double-digit environment.
Well, that's very interesting.
Yeah.
I mean, and it's just, I guess it is higher than headline inflation. We know that, but I think it'll be manageable, particularly seen as what you're getting.
Yeah, I mean, and I think the key point is that many years we see an increase in premiums, but decrease in benefits.
Correct.
The fact that you're saying that we're seeing here, okay, increased premium, which we expect that at a reasonable rate, but not a decrease in benefits. Actually, important.
Maybe just to put it into context of where we sit from a gap cover provider is the impact normally when there's a reduction in benefits, the introduction of co-payments is more. So it does affect our environment. So I think the environment for 2026 will be more or less equalized. I mean, not to say we're going to have less claims, because the risk profile of the medical scheme member in our country is rising. Sickness conditions and the burden of disease is getting higher. So medical schemes and gap cover providers will be impacted. It's the way we manage and ensuring at the same time what the member pays for, the quality outcomes is achieved.
Yeah.
Yeah. Well, that all makes sense. And I think, look, I mean, it's a good message ultimately. A great way to end this episode. I know we've got some great topics coming up.
Definitely some great topics as we head towards the end of the year. So listeners should look out for that.
Yes.
And some exciting information. So a lot of interesting medical stuff coming up.
Sure. And as usual, to all our viewers out there, if you have queries for the team, you know the address. It's on the screen now. Ask Dr. Avron at totalrisksa.co.za. Send us the questions. We will discuss it, and we'll get back to you with what we feel needs to hear.
If I can ask the list, also if there's specific medical topics you like to hear, we'll get the specialists, we'll get the experts around the country to actually answer those questions for you and those topics for you. So
great.
Yes, and to you, the consumer, this podcast is for you. As Dr. Avron has said, we want to address the needs that you have. So please email Dr. Avron, and we will put the necessary topics on for you and have discussion around it. Thank you.
Great. Thanks, guys.
Excellent way to end off. Thanks, everyone.
Thanks. Cheers. Bye.
Cheers.
Cheers.
Don't stress, the gap is covered.
Well, there we go. Thank you to the TRA team and to you for watching the Inside Track. Until next time, bye for now.